Hello, my name is Pavlovsky, and I'm Director of Psoriasis and Phototherapy Service in Rabin Medical Center and Clinical Associate Professor of Dermatology in Tel Aviv University in Israel. I'm really excited to spend the next 10 minutes talking about psoriasis and inflammatory bowel disease, their overlapping pathways and treatment considerations. These are my disclosures of conflicts of interest. Presentation content, we will start talking about psoriasis and IBD, pathophysiology and mutual risk factors. Then we will discuss treating inflammatory bowel disease in a patient with psoriasis, and then treating psoriasis in a patient with IBD. And in the end, we will discuss anti-tumor necrosis factor alpha induced skin diseases. So regarding mutual risk factors, we know from many different genome-wide association studies that inflammatory bowel and psoriasis share common genetic loci involving pathways of interleukin-23, as you can see here. In this recently published meta-analysis, we can see estimated prevalence of inflammatory bowel disease in patients with psoriasis. And as you can see, the most common association is having psoriasis in Crohn's disease patient. It is less common in UC patient. And regarding vice versa association of IBD and psoriasis patients, it is also relatively common. And again, Crohn's disease is more common in patients with psoriasis than ulcerative colitis. So, summary, this epidemiological data, we can conclude that the most common association is to have psoriasis in a patient with Crohn's disease. What about pathophysiology? And in this nice review recently published in Journal of Internal Medicine, we can see that both diseases start with apparent antigen presentation in impaired mucosal barrier in case of IBD, and probably antigen coming from keratinocytes or melanocytes in case of psoriasis, as you probably know. In both diseases, dendritic cells are involved, and the cytokine, one of the most important cytokines here is TNF. And as we know, treatments against TNF are widely used for both diseases. And our immunological pathway involved in both diseases are T helper cells, and they are cytokines as anti-interleukin-23 and medications anti-interleukin-23, and again, both are used in both diseases. But also we know that interleukin-17, which is a product of pathogen T helper 17 cells, is important cytokine in both diseases, but neutralizing interleukin-17 is very helpful in psoriasis, but harmless in inflammatory bowel disease, and probably showing us that interleukin-17 has some positive or physiological role in the bowel, and we will discuss it a little bit later. So, to treat IBD in a patient with psoriasis, we should consider what are existing treatments for IBD and what influence they may have on psoriasis. So, sulfasalazine, it is still widely used treatment, and mainly in the field of rheumatology, and this is nothing to do with psoriasis. Corticosteroids, systemic corticosteroids, as we know, we don't use usually as a treatment for psoriasis, but it is used by our rheumatology colleagues to treat psoriatic arthritis in some situations. Topical corticosteroids, of course, are widely used medications in psoriasis also. And next, systemic treatments here, tioprins, 6-mercaptopurine, diazoxytioprine, are still widely used in gastroenterology. And talking about patients with psoriasis, we should consider the possible risk for non-melanoma skin cancers using this treatment, especially in combination with phototherapy for psoriasis, which should be avoided. So this is the consideration for these medications. 5-ASA and budesonide, they have nothing to do with psoriasis, and methotrexate, as we all know, is still widely used in treating patients with psoriasis, and especially with psoriatic arthritis. Cyclosporine we also use in psoriasis, usually is a bridge treatment in some special situations, and tacrolimus is not widely used in psoriasis. So regarding biologics, infliximab and adalimumab are used and approved to treat psoriasis. Golimumab is another anti-TNF, which is approved for psoriatic arthritis, but not for psoriasis. Vedolizumab is medication that is used to treat IBD, but no effect, even positive or negative effect on skin disease. And ustekinumab is widely used from 2009 to treat psoriasis and after that psoriatic arthritis, and it is widely used in IBD. Tofacitinib is approved for psoriatic arthritis, but not approved, at least by FDA, for psoriasis. Recently, 2 new medications were approved: risankizumab for Crohn's disease and upadacitinib for ulcerative colitis. And risankizumab is a very effective medication to treat psoriasis. Upadacitinib is approved for psoriatic arthritis, but is not approved for skin disease. What about treating psoriasis in a patient with IBD? These are medications approved for psoriasis. So as we discussed, corticosteroids and methotrexate are used also for IBD. Phototherapy is not relevant for IBD, and the only consideration is regarding non-melanoma skin cancer, as I mentioned before. Apremilast. Apremilast is medication which we use to treat psoriasis and psoriatic arthritis in some situations. And the main factor to consider giving apremilast to patients with IBD is possible gastrointestinal side effects, especially in the beginning of treatment, and mainly diarrhea. So giving this medication for patient with IBD, we should talk with the patient and with the gastroenterologist that diarrhea is a common side effect, and it may be challenging to make differential diagnosis between diarrhea caused by the apremilast and by basic IBD. But again, we can use this medication properly in some situations, of course. What about biologics approved for psoriasis? So infliximab, etanercept, adalimumab are all used for psoriasis and psoriatic arthritis for many years, and infliximab and adalimumab are used widely for IBD, and maybe still are the first-line biologics for IBD. Ustekinumab, as I mentioned before, is used from 2009 to treat psoriasis and is also approved for IBD. And the next group of medications is anti-IL-17s, secukinumab, exekizumab, brodanumab, and very recently approved in Europe and in Israel, bimekizumab, which is still not approved by FDA. So all these medications are very effective medications for skin disease and for psoriatic arthritis, but all are contraindicated, or at least awareness should exist for prescribing them to patients with IBD, because it was shown previously that they may exacerbate IBD, and these medications will not be a good choice for patients having IBD to treat the psoriasis. The other consideration that we should think about prescribing biologics for psoriasis patients with IBD is the dosage, because for all these medications, dosages used for IBD are much higher than for psoriasis. So if you want to prescribe this medication for patients with psoriasis who also has IBD, and we want him to have benefit from the IBD point of view, we should use appropriate dosage, and this is again a good reason to collaborate with gastroenterologists. And what about anti-TNF-induced skin disease? In this very nice review recently published in Lancet, it was proposed that we can classify psoriasis according to pathophysiology in three groups: like plaque psoriasis, mainly driven by interleukin 17, paradoxical psoriasis, mainly driven by interferon, and pustular psoriasis, driven by IL-36. So, treating patients with skin lesions associated with anti-TNF is one of my special topics of interest, and we work in collaboration with IBD unit in our institution. So, this paper was published in Annals of Internal Medicine a couple of years ago, and summarized very large cohort of almost 1,000 patients with IBD, and more than 200 of them developed skin lesions. And these findings actually reflect also our experience. So, it is important to note that median time for the development of skin lesions was 1.9 years. It's not unusual to see patients starting suffering from skin lesion induced by the TNF 2 or 3 years after initiation of the therapy. It is relatively common here, is almost 30% of patients, of course with different degrees of severity. And what about the clinical presentation? It was previously called paradoxical psoriasis, but I think that it is inappropriate to use this term because most of these patients, their rash, their skin disease is psoriasis from dermatitis and not actual psoriasis, even from the clinical and pathophysiological point of view and immunological, as I mentioned before. And in this cohort, 30% of patients did have this psoriasis from eczema, and only 5% palmoplantar pustulosis, which is relatively common in a different population of patients suffering from rheumatological diseases, for example, rheumatoid arthritis treated with anti-TNF. So in this population, palmoplantar pustular psoriasis, palmoplantar are more common. But in IBD patients, it's relatively uncommon, and true psoriasis, I mean, exacerbation of psoriasis or de novo true psoriasis, is also relatively uncommon. So the most common form is psoriasis from dermatitis. The lesions typically develop at flexural regions, genitalia, and the scalp. And as you understand, these lesions are very common for psoriasis. So maybe this is one of the reasons in the past we call it the paradoxical psoriasis, or paradoxical skin disease. And the scalp. Scalp is a special site, and I will discuss it a bit of later. And here you can see examples of skin rashes from this paper in Annals of Internal Medicine, and common sites of involvement, and again, morphology of psoriasis from dermatitis, sometimes with secondary infection. And this picture is of inflammatory alopecia. We call it anti-TNF-induced inflammatory alopecia, and the special clinical form of scalp involvement in these patients causing alopecia and severe inflammation of the scalp, as you can see here. On histology, you can see psoriasis from epidermal hyperplasia and mixed inflammatory infiltrate involving also hair follicles and miniaturization of the hair follicles, explaining the alopecia. And it should be noted that in all cases, we have treated almost 20 patients with this disease, and this is reversible after discontinuation of treatment. So how to manage patients of IBD suffering from anti-TNF-induced skin lesions? And this is in our cohort published in the Journal of Bronchiolitis recently with 180 patients. And their main findings were that scalp location was independently associated with less remission of skin lesions, and that early switch of ending biologic was independently associated with a higher probability of remission of skin lesions. Actually, it was also our conclusion, and this is a paper we published recently, and what we found that when you have patients with skin eruption induced by anti-TNF, first we should decide if there is severe inflammatory alopecia or not, because in the patient with severe inflammatory alopecia, it is mandatory to switch the biologic to the another group. In our case, it was Stellara, but these days there are another medications available. And in the case of psoriasis from dermatitis without inflammatory alopecia, there is a probability to keep anti-TNF, the offending anti-TNF or maybe different anti-TNF, and because as you probably know, this is something that's very important to the patients from the IBD point of view. So not always in case of skin involvement only, it is necessary to switch biologic, but in cases of inflammatory alopecia, it is very important and as soon as possible. So for this clinical team, I would like to summarize and to thank you for your attention.